So for those of you that don't know me, I'm Matt Halanski. I'm one of the pediatric orthopedic surgeons here at UW, and spend a bit of time in the different multidisciplinary clinics, the neuromuscular multidisciplinary clinics, including the CP clinic here as well as the spasticity clinic here. And usually we're supposed to give some disclosures, and really don't have any financial disclosures to this. However, I'm the only surgeon talking, but one thing always to remember is when you're going to talk to somebody or see somebody, your bias is always going to be towards what those people do. And I make my living operating, so my bias will be towards operating. If you see somebody who does physical therapy, they'll probably be towards physical therapy. So just always keep that in mind when you feel like you might be getting different answers from different people. We kind of talk about what we know. I'd also like to thank my partner, Ken Noonan. He's given me a couple slides and photos and movies in here, which hopefully will make this a little more interesting. So overview of the talk, just talk about a little bit of background and then do some clarifications. While I am a surgeon and I like to operate, I find probably most of my time spent with patients and families is talking them out of surgery and explaining what the surgery will and won't do. And we'll kind of go through that a little bit. Then I'll just go through some of the procedures. Now, to be fair, these are going to be mostly limited to things that we do in kids, not so much in adults. Some of them could be done in either, but often we perform these in children. And most of these deal with lower extremity issues, but the techniques can involve the upper extremity as well. And kind of just the indications, kind of what the procedures are when you hear these words thrown around, and then what the anticipated recovery is. And then there'll definitely be time for some questions. And so while Dr. Bragg isn't here, and it's good because she probably wouldn't let me live this down, it's always important to remember the problem with cerebral palsy is a problem in the central nervous system. It's not a primary problem of orthopedics. And with that, you have your brain. Your brain sends out the signals through the spinal cord, which then goes to your muscles. And with us that don't have issues with that, it's something that happens very easily and naturally. But that's not necessarily the case with children with cerebral palsy. And it's this brain involvement. While we see this here, we see the movement disorder, we see the problems that the children have or the adults have when they're trying to get around or do things. You have to remember that the cause is what's going on in the brain. And so it's the brain that's the problem that's causing the abnormal movements. But in general, people see the abnormal movements or see the foot that doesn't work and thinks the foot's the problem. And it's very important to remember that's not the fundamental problem. And we tend to use this, you've probably heard this if you've been in clinics, the GMFCS level or the gross motor functional scale level. And this is very useful. Children typically at different ages, this is for a child 6 to 12 years old, these classifications go younger and older, but in general, there are different levels that individuals fall into, and it's important. What makes them fall into each of these levels, again, has to do with the brain. The brain determines which level the child's going to fall into. The brain also, in some ways, determines, I don't know if you can see that picture there or not, but the child has a dislocated left hip. The brain, what's going on there causes the dislocation, which then does not cause which level they're going to fall into. It's what's going on in the brain that causes which level of function they have. It's not the fact that their hip's dislocated that's keeping them from achieving another level. And if we look at that over time, what we see is that children, once they're in a GMFCS level, they generally stay in that GMFCS level if it's appropriately determined over time. And the only thing that happens is typically they may go down slightly within that level, their functional scores, as they get older. In those last 3 slides, I will tell you I have to say over and over and try to explain that in many, many ways, because I don't want to believe that, and often patients don't want to believe that, and families don't want to believe that, but that is the truth. So and this goes to the next slide, what orthopedic surgery does is it doesn't improve levels, it tries to maintain things. It tries to, when people have contractures, it tries to increase the motion. It may decrease pain while they're doing things. It may improve brace tolerance, and it will maintain or improve within those levels. What I can't do is I can't change the spasticity or tone through surgery. Dr. Bragg potentially can do that with her surgeries, but with orthopedic surgeries, there's not a way I can change tone. Often we don't eliminate the need for braces. That's another common thing, that people think that after they have surgery, they're not going to need braces anymore. That's usually not true either. Often they still need the braces, but we hope that what we do can make them more comfortable. And then probably most important is we don't, see here, hold on. We don't change GMFCS levels, okay? When I do a surgery on somebody's hips or make their legs go straight, if they're in this GMFCS level 4, if they need assistance all the time, they're still going to need most likely assistance all the time. I'm not all of a sudden going to make them into a community ambulator. And this is really, 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 really important to understand. Probably the most important thing that I'll talk about. Now, the problem with spasticity from an orthopedic standpoint over time is that you have this uncontrollable or mistimed muscle function when people are trying to do things. Because of that spasticity, the muscles are stiffer than normal. And when you add stiff muscles with bones that grow, if the muscle can't keep up, what ends up happening is you get contractures. You lose motion at the joints. This muscle's not growing as it should normally. The bones continue to grow as children continue to grow, and you develop contractures. That's why often we see children really get into trouble around the time of adolescence when they're growing quicker. And over time, that can actually lead, there's a phenomenon called the Hutter-Volkmann phenomenon, which has to do with how bones grow. And bones grow less under compression than they do under tension. So you can actually have over time the actual shape of the bones remodel when they're under these forces over time. Now, non-operative management is the mainstay, especially for young children. Really, it's focusing on physical therapy to keep those muscles stretched, to keep motion, using tone management through different medications, Botox, surgical procedures, to try decreasing that tone on them. And also the use of bracing to try keeping those muscles from tightening up or shortening more. So, as I kind of said before, when you have tone and you have growth, that's often when you see problems. And this does often occur despite non-operative treatment. And this is getting at what the other slide was showing, that you have, as you grow, these muscles are tight, you have bones that grow, contractures develop. Despite therapy, bracing, other things, this often happens, and it's not a failure of anybody, it's just often what we see physiologically as kids get older. And when kids are young, they can typically tolerate this pretty well. When they weigh 5 pounds, being up on their toes all day is not a big problem. When they're 235 pounds, then it becomes a problem. So this is why we often see, if you remember that those graphs of the GMFCS levels, a little bit of that tailing off towards adolescence or later. This is where things become difficult. Children who are marginal ambulators don't stay ambulatory. It's because all of these little effects have a much bigger physiologic effect on them to be able to maintain their function. So what do we do when these muscles become too tight, when they're not long enough to be able to allow the motion? This is typically where, from an orthopedic standpoint, we start to get involved. And often what we do is what we call muscle lengthening. Some of the most common sites are the adductors, so the groin muscles, difficulty in kind of spreading the legs apart for perineal hygiene or for walking, for that matter, something that can kind of cause scissoring, with the hamstrings as well. The hamstrings are often affected, as are the heel cords, either one or both of the muscles down by the heel. And so lengthening can mean any of a few different procedures. It can mean from showing you right on this side here. It can mean anything from isolating a tendon, so that's what a tendon looks like, and just cutting it. And what happens is you cut that tendon, you'll let the ends not even touch, and over time scar tissue develops between them. So you have to cut the tendon and leave the joint in the position you want it to heal in to gain that motion. The other is cutting the fascia. So the fascia is kind of like, might be a little bit gross, but thinking about a steak, and if there's gristle in a steak, that hard material around the outside, or rigid material, that's what the gristle is. So sometimes when we do a lengthening, we just cut that gristle but leave all the muscle attached. So all the muscle on the inside's fine, and that's kind of what you're seeing here. Let's see if I can get it over the button here. Maybe, probably shooting myself. There we go. So this is the gristle, and this is just a cut through it. Then the last is what we call a Z lengthening. And if this is the tendon, so let's say this is the tendon, we kind of make a step cut like this. We move the joint to where we want it, and then we sew that back together. And so over time, these areas kind of fill in with scar and tendon. The recovery on a lengthening typically is out of all the things that we do, okay. There's definitely some problems with pain and muscle spasms afterwards, but typically we cast a person in the position that we're trying to gain motion. So if the foot won't get flat on the ground, we kind of cast them at 90 degrees or slightly more. Same thing with the knees or the hamstrings. And really, we try to hold them in that position for about 4 to 6 weeks. And the biggest complications with this are recurrence. This is why we tend to look at using Botox and other methods when kids are 3 and 4 years old. If we do this when somebody's 3 or 4 years old, there's a very good chance we're going to have to do that once or twice more before they reach their adult size. And every time we do one of these procedures, when we lengthen, we weaken that muscle. Okay, so it's not. While they're rather small procedures, they're not without a consequence down the road. So the next kind of group of procedures that we'll talk about are tendon transfers. So as we said before, the idea of a spastic muscle is a muscle that's always turned on. It just doesn't, or it turns on when it shouldn't turn on. And that can be a problem. Over time, we can have these deformities develop. And so one of our strategies, instead of just weakening that muscle, is if a muscle's pulling in a direction that's causing a deformity, can we use that same pull to correct the deformity or help the deformity out? And so idea of a rectus transfer is a child who has a very stiff knee gait. The rectus is one of the quadricep muscles. If they can't get bend at their knee as they're trying to walk, sometimes we take that tendon off of the kneecap and actually move it around to the back of the knee to help with, instead of keeping the knee straight, trying to get the knee to flex as the child's walking. Another one, these are just different tendons in the body, is the anterior tibialis tendon. That's a tendon on the front of the foot. And the other that I'll kind of show more involved stuff with these pictures in a little video is the posterior tibialis tendon. And so that's really dark, isn't it? You can't see. Apologize for that. But so the posterior tibialis tendon, often what will happen when somebody has a contracture of that or has spasticity of it is that the foot is inverted, and often going along with that is the child will toe walk as well, because often the heel cord becomes tight. So it's a very kind of classic foot pattern that we see. And you can see there, that's the tibialis posterior tendon actually kind of sticking out of the skin almost, you can see, because it's so spastic on this patient. So instead of, you can kind of see here, this tips the foot in, and you can see the heel's tipped in, and this is that tendon right there. So what we try to do is we actually take half of that tendon and move it around to the other side of the foot behind the ankle. And that's what this is showing, the split there. And we do this I'm kind of just trying to demonstrate an example of what tendon transfers do. This is just one of them. There are lots of different tendon transfers. And this kind of just shows a little bit what that looks like. So I try to leave out all the gross pictures. So this is just finding that tendon. We take half of the tendon, we bring it up kind of above the ankle, we bring it behind the ankle joint. This is coming out on the outside of the foot. And then we sew it into another tendon on the outside of the foot here. Okay, so instead of it just pulling on the inside of the foot, now it's going to pull on the inside and on the outside of the foot. And this is an example of a child before. So you can see his foot's tipped in, he's up on his toes. And this is him, I want to say 4 years later. And you can see, if anything, that actually may have potentially overcorrected a little bit. He went from kind of in-toeing and inverting to he's almost everted on that. But that is, these tendon transfers can be very powerful. You're kind of using what's wrong to correct the deformity. Now, despite these being pretty powerful, the recovery is not, if these are done alone, is not that difficult. It's very similar to a tendon lengthening. Probably muscle spasms are the biggest problem in pain with those. Typically, we cast anywhere from 6 weeks to 3 months, often allowing the child to weight bear if that's all that's done. And then often we may do increased or more rigid brace wear than they had before. So a foot procedure, we may have them in a solid AFO afterwards for maybe a year to let that really heal in. This is probably one of our most common procedures that we do, especially around the hip. It's called a VDRO, if you've heard that. It's a varus derotational osteotomy, and sometimes we combine that with a pelvic osteotomy. And in cerebral palsy, one of the big problems is you have abnormal muscle pulls, as we talked, and the bones grow abnormally, as we said. And in the femur, what that means is there's often valgus, which means not enough bend up here. This side is less affected, so you can see normally there's a bit of a bend to the femur up there. They're a bit straighter than normal. There's too much twist, which really doesn't show up on this x-ray. And the socket tends to be a little shallower than it should be. And you can see a lot of that has to do with chronic tone kind of on that hip. So you have these adductors that are tight, psoas that's tight, and that tends to drive the hip out of the socket. And so the varus derotational osteotomy, this is where people think we're crazy in orthopedics, is literally what we do is we go in and we cut that femur and we put a plate on it with screws that tips that ball into the socket. And if you look, you can see, so we took this bone that looked too straight and we put more bend in it. But even still, and it may not show up that well to you, the socket still doesn't look like this side. It still looks like that socket's very, very high. So that's where we do sometimes what's called a pelvic osteotomy. And literally, we cut right above the socket to change the shape of the socket. And so we kind of do that and lever that down and then pack bone in there. And this is just an example of that child there with kind of the pelvis being cut. And then you can kind of see this piece of bone graft that we put in there to kind of push where the socket's up, it's pushing that down more. And this is kind of the before and after. And often we do these bilaterally, even if one side's affected, because if we don't, often that will lead to a pretty significant limb length discrepancy. And sometimes if the child does have tone bilaterally, only correcting the one side, you can sometimes, often this leg, if this is the one that's affected, sits adducted, so it's almost across and it holds the other one out. And if we correct one leg and get it out, the other one may come back over after. So rather than having to go back in a year or two later, often we'll do both of them at the same time. It's not always the case, but it's usual. The recovery, I would say is kind of the granddaddy of them all, taking care of a lot of these kids. I'll talk about spine surgery next, but recovery-wise, this seems to be the most difficult kids have to recover from. There's really a lot of problems early on with pain and muscle spasms. Typically, kids are in the hospital for about a week. They may require a hip spica cast, as seen here. We've really tried to get away from that just because there can be a fair number of complications just associated with the casting. But I would say sometimes the kids are more comfortable in the cast than when they're not. And typically the kids are non-weight bearing for about 4 to 6 weeks after this. And those plates that you saw us put in, often we take out in about a year. I'm really briefly just going to talk about semmels. This can mean a lot of different things to different people. But the idea is that in the past, what would be done is the child might have tight hamstrings and they would have their hamstrings lengthened, and then it would look like they had tight heel cords, so their heel cords would be lengthened, and then it would look like their hips were coming out, so they'd have their hip surgery. So every other year, a child might be in or out of surgery, rehab, having all this done. So what's the switch has been is to basically do everything at once. So if a child has problems at the hips, has problems at the knees, has problems at the feet, they have one really long day in surgery, they have a longer convalescence in the hospital, but then they have one rehab program to kind of get them back where they're supposed to be. If you read stuff from Gillette, what often semmels includes, and it's kind of outside the scope of this talk, is what we call a distal femoral extension osteotomy and patellar tendon advancement. Usually they include that in most things, and I can definitely talk more about that, but really semmels is any time we're trying to do multi-level surgery at one time to try getting a child just to have one recovery. And this is something really important I try to stress to the parents, that really it may take 6 months to get to where you were before surgery, and really it can take a year to potentially see the benefits from a surgery like that. Okay, so this will be the last kind of procedure that I'll talk about. So scoliosis. This is most common in the kids with GMFCS levels 4 and 5. It's often progressive, and one of the problems is it can make seating difficult, can make hygiene difficult, and really it can affect pulmonary function at around 60 degrees. And what tends to happen is, and you can see it, and when I say progressive, this is just an example of one child that, I don't know if you can see his spine, there's some numbers on here, but here was the spine here, and then it does this here, and then it does this here. And what tends to happen is we see a child in this range, usually about 50 degrees to 60 degrees is where we talk about doing surgery. And often parents and families aren't quite ready to do it then, or they say, no, we're not going to do spine surgery. And then they come back a year later and it looks like this, and then it's a lot harder surgery on the child and the family and me, and with a lot more risks. And so everybody kind of has their own, it's a big surgery and you have to be ready for it, but often I think people get ready a little bit too late for it. And it ends up being a little bit more difficult on everyone. The goals of it, everybody thinks this is the goal. The goal is to take a spine that does that and do that. And it is, but the primary goal of posterior spinal fusion is to halt progression of the curve. So we want to keep it where it's at. Usually when children are here, or on this page when they're here, they're actually doing okay. They're usually not having a whole lot of problems. But the problem with it is it's likely going to keep getting worse if we don't do anything. And so the first goal is to halt the progression. The second is, and in these children is to try giving a good seating balance and keeping the head over the pelvis. Then the last one is to straighten the spine. Sometimes when we operate on larger curves early, they can be very flexible like this and we can get them straight. Other times when we wait, this is a pretty gnarly spine. And really, you can see, this is after we do surgery, and people are like, did you do anything? I can tell you, this was probably one of the most difficult cases I've done. And a lot of it has to do with the stiffness of the curve. There's only so much we can do to correct a curve. A lot of these children are on anti-seizure medications, which makes their bones not real good, as well as nutrition issues, which makes their bones not real good. And so I've got metal I can put in, but that metal will tear right through the bone if the bone's not good. So it's this limit of how hard do you push before everything falls apart versus how straight you can get somebody. And I've had this on the day of surgery, even though I've talked to people multiple times about it. When we do a fusion, any of the areas we have metal will never move again. If it moves, that's a problem. That means my surgery didn't work. It also eliminates all growth over those levels. So I always tell parents this, but this is one area that the day of surgery will be, are they going to be able to bend through that area? No. There's big metal bars in there that prevent that. I think there we go. So the procedure is pretty, technically it can be difficult, but it's thinking about it's pretty simple. We kind of expose the spine, we peel the muscles back off the spine, we put fixation points in, and we put our rods in. And that usually can take about 6 to 8 hours to do. There are significant complications with this. Blood loss is a big one in children with cerebral palsy. You can have postoperative pulmonary complications. Infections are much higher in these children than in the general population. You can have neurologic injury, and sometimes families don't, I don't want to say don't care about that, but are often like, he or she doesn't walk anyways, what matters if their spinal cord gets hurt. Can affect bowel and bladder function, and that can really be a problem. So we often do still monitor these kids during surgery to make sure we're not injuring anything neurologically. And then many of the kids, probably the number one, I don't know if I'd necessarily call it complication because almost everybody has it, is really the kids can have a post-op, what we call ileus, or difficulty getting back feeding. Usually these surgeries, they have a lot of fluids that they're given. They're on a lot of pain medication, and it can really take a long time for kids who struggle with constipation to get their bellies back working. The typical course is a few days in the ICU, and usually about a week to 10 days, many of these children are around. Probably 3 days is the quickest anybody's left, and probably, on 10 days is probably about a week is average. We get them sitting up as soon as they're possible, so if their breathing tube comes out after surgery, usually the next day in the ICU we have them sitting up in bed. If they're ambulatory, usually we have them walking by day 3 or day 4, and most of the kids are able to return to school about a month out from their surgery. So just a final thought regarding kind of any operative surgical experience is really the one thing I try to stress to people is you got to have a realistic goal or a specific goal that you're trying to accomplish when we're doing surgery. I can lengthen a child's hamstrings that's in a wheelchair all the time, but unless we're going to do something like try to get them in a stander or have other functional goals that we're going to do, those knee flexion contractures are going to come back, and I just put somebody through a surgery they didn't need to be put through. And so it's just important before we do something to say, okay, we're doing this because of, and it's not a value judgment on what that is, it's just not doing it to get range. That for me is not a reason to put a kid through a surgery like this. It's to be able to do something. If it's getting rid of pain, if it's helping them do some, a family goal. So in summary, we often, basically what we do is treat the effects of kind of long-term tone in one way or another. Often we do these as an adjunct to tone management. The results of the orthopedic surgery will not be as good and will not last as long if the underlying tone is not managed appropriately. Our goals are usually to increase range of motion and prevent a deformity progression, but we remember all of this is happening within a GMFCS level. We're not improving that level. And depending on what we do and how many different things we do at one time, really the invasiveness and the recovery times vary. So I'd be happy to take questions. I don't know where we are on time. Hopefully I'm pretty close to where we should be.